Kidney shutdown or acute kidney injury is a major complication in critical illness or following surgery. Today we'll talk about what makes your kidneys vulnerable, what are the causes of kidney failure, what are its consequences, and how we diagnose it. My name is Demirjian, and this is Kidney Guide.
Acute kidney injury, or failing kidneys, is drop in kidney function over hours to days, resulting in retention of waste products, toxins, and dysregulation of electrolytes, acid base, and volume homeostasis, or balance. Your kidney is a bean-shaped organ the size of your fist, has an outer part called cortex, and the inner area called medulla, which consists of collection of tubes that merge to form the renal pelvis in the center of the kidney. Urine collects in the pelvis and drains into the ureters. From the aorta, each kidney receives a renal artery for blood supply and subsequently drained through the renal veins to the inferior vena cava. A common cause of kidney failure is volume depletion, such as what happens with severe diarrhea or vomiting. Hemodynamic and perfusion issues play a major role in kidneys shutting down in patients with heart and liver failure as well. Now, these are all usually perennial, in other words, are reversible with no structural damage unless the underlying problem persists and is not reversed easily. To better understand why kidneys are susceptible to injury, specifically due to low perfusion or low blood pressure, despite receiving 20% of the cardiac output, probably need to look closely to the structural units, the nephrons. You have about 1 million of these tiny filters in each kidney, where the red part, the glomerulus, is a specialized blood vessel which filters out the plasma water, which contains all the waste products. That convoluted long tubule, the tubular structure, reabsorbs some of the major or essential electrolytes and other things back to your body. Moreover, flow to the kidney is not uniform, and most of it is directed to the cortex for glomerular filtration, where cortical tissue oxygen is about 50 to 100, whereas the medulla is watershed area and depends on vasa recta for blood supply. Countercurrent oxygen exchange puts much of the last portion of proximal tubule S3, the loop and medullary thick ascending limb, in borderline oxygen-deprived state. Let's take a closer look at the glomerulus. Here you have the afferent arteriole bringing blood to the glomerulus or tuft of capillaries, which push out the blood water to the tubule and then continues as the efferent arteriole to form the vasa recta. Kidneys can maintain their function in the face of hemodynamic stress, for a while at least, through the process of autoregulation, where the afferent and efferent arterioles respond to blood pressure changes by dilating the afferent arteriole and constricting the efferent. You can maintain filtration constant to continue doing your job, cleaning waste products. And the other way the kidneys respond to hemodynamic stressors is by low chloride concentration in the tubules through the macula densa. It is able to send a loop back to further dilate the arteriole to improve filtration, and also send renin systemically to increase systemic blood pressures. And these perennial states, they persist long enough or they are severe enough, can result in tubular injury, especially in those susceptible areas in your kidneys. Other ways you can injure your tubules is use of iodinated intravenous contrast and many medications, including antibiotics, antiviral medication, immunosuppressive medication, and such. Another compartment in your kidneys which is susceptible to kidney failure or kidney injury is your blood vessels, particularly small blood vessels, such as it happens with vasculitis, atheroembolic disease, or thrombotic microangiopathy. Interstitial compartment is also prone to allergic reactions to medications, such as the case in acute interstitial nephritis, to certain poisons, and infection of the kidney overall. Postrenal AKI refers to any kind of obstruction, the urinary pathway as it leaves your kidneys. This could be in the ureters or in the bladder. Simple reason could be a stone lodged in the ureter, which will interfere with the urine coming to the bladder, or retention due to enlarged prostate. Acute kidney failure diagnosis is typically made based on increase in serum creatinine levels over a few days. Creatinine precursor creatine is synthesized in the liver. This is the same bodybuilding supplement which has been popular recently. Creatine phosphate is the main energy phosphate storage molecule of muscles, where it recharges consumed ADP to ATP. Then creatinine is mainly filtered by the kidney and as such is a reflection of your kidney function. In a 24-hour period, one can produce around 1,500 milligrams of creatinine based on their muscle mass and protein intake. And if they have a normal kidney function, which is about 100 mLs per minute of GFR, which translates about 144 liters over 24 hours, then their creatinine level will be about 10 milligrams per liter. Now we convert that to deciliter by dividing by another 10, and that will be 1 milligrams per deciliter, conveniently. Now when your kidneys are shutting down, that creatinine goes up because you're not filtering or getting rid of it. And in fact, when it doubles, that reflex drop almost 50% in your underlying filtration rate, or GFR. Complications related to your kidney shutting down include disruptions in your body electrolytes, predominantly potassium, phosphate, sodium, and bicarb levels, which dictate your blood acidity. Now, what you'll have is acute rise in potassium levels, which could be very problematic since it can interfere with the electricity of your heart. It also can cause problems with increase in phosphate, with deposition and bone problems. This is more of a chronic problem. But a drop in sodium concentration because of the accumulation of water can lead to major mental complications, including seizures and coma. And of course, increased acidity in your blood will cause problems with your heart and blood pressure. Now, typically, as kidneys shut down, you stop making enough urine, which lead to water weight retention in your legs, typically in your lungs, where you have problems with breathing, and it can also cause nausea, vomiting, and other uremic symptoms. And unfortunately, AKI is associated with bad outcomes. Definitely, increased length of hospital stay is a major issue with kidney complications. Rehospitalization or readmission following index hospitalization with acute kidney injury, a major problem. Chronic kidney disease and requirement of dialysis could be a problem if your acute kidney injury does not reverse or does not get better over time. And it's also associated with reduced survival, strongly associated with increased mortality. Now, let's take a look at a kidney problem evolving in a hospitalized setting. Let's say somebody who's undergoing surgery. We typically look at their kidney function reflected by their creatinine pre-surgery, during surgery, and after surgery. In this case, let's assume somebody's creatinine is stable during the course of the surgery, which reflects a stable GFR. But then let's assume there's an event during the surgery and there is an actual drop in kidney function, which is not measured directly, but then what's reflected is the rise in serum creatinine over a couple of days after surgery, which indicates then, yes, in fact, there has been a change in underlying kidney function due to an event that potentially happened during surgery or right after surgery.
Hope you enjoyed the presentation.